So I've been asked to talk about anterior approaches and surgical techniques, and I'll try to give you some perspectives on how I kind of approach this, and then also I wanted to share with you just very briefly some of the recent guidelines that have been published from AO Spine. But before that, some thanks. So I just, again, want to recognize Professor Farshad. Thank you very much for the invitation. Also for Professor Kurt and Armin. Armin and I go back many years. We have many stories to tell. And I always enjoy making new friends. And there we are last evening and enjoying the faculty dinner. So it's a lot of fun to be here. So I have no commercial disclosures, a number of sources of grant support. This is where I work in Toronto. You're all very welcome to visit us in the clinic, and we have some former fellows here in the audience, and we have a fantastic team that I'd like to also acknowledge. And just by way of invitation, if you need an excuse to come to Toronto, this is a pretty good excuse. This is the International Neurotrauma Symposium. This will be a big meeting. So for those of you that are interested in spinal cord injury, this will comprise a significant amount of this meeting. It will also be involved in traumatic brain injury, and I think certainly for a number of people in the audience, perhaps you treat both of these conditions, but there'll be a significant amount of clinical material presented here. So Professor Farshad has given a nice summary of degenerative cervical myelopathy. This is actually a relatively new term that we coined. And I did this because when we started publishing some of our studies on cervical myelopathy, I had always used the term cervical spondylotic myelopathy as the overarching term. And once you start publishing, the peer review process can be, you can get bruised a little bit. And so some of the reviewers were saying, well, wait a minute, CSM is not the same as OPLL and so on. And of course, that's correct. But these are all conditions that are part of the spectrum of this disorder. And so I want to thank whoever the reviewer was for challenging us. And so we came up with this term of degenerative cervical myelopathy. And I was pleased to see that Professor Farshad was using this term. And we think about the static injury, we think about the dynamic components of this. And of course, there are the molecular and cellular events intrinsic to injury to the cord. But I'm really going to focus a fair bit in my talk on biomechanical principles. And when one is thinking about, okay, the decision to operate, so Professor Farshad outlined kind of who we should be operating on, but then the decision who to operate, anterior versus posterior, multi-level, single level, and so on, you want to get an idea about some of the cervical alignment parameters. And so some of the concepts here in terms of measurement of cervical lordosis, the sagittal vertebral axis, SVA, is quite an important number, and this should be ideally less than 4 centimeters. You want to be looking at the chin-brow vertical angle. This can be a significant issue as well. And then an important concept to look at is the T1 slope. And so I pay a lot of attention to the extent of lordosis or kyphosis, the T1 slope, as well as the SVA in terms of decision making. You want to assess the patient clinically, so you want to look at the whole spine, and in many circumstances, actually getting a 3-foot standing X-ray is quite helpful. In these days, there are very low radiation-based systems, so that you can do this quite efficiently. And this isn't just gilding the lily. So this is important because for example, the C2 to C7 SVA is correlated with the neck disability index and the SF36 in degenerative cervical myelopathy. And cervical deformity is associated with greater disability and poorer quality of life in degenerative cervical myelopathy. Now, not all of this, of course, is going to be reversible with surgical treatment, but it is important nonetheless to take this into consideration and to try within reason to try to correct this at the time of surgery. And we saw this in the case illustration where there was a reduction of the C3-4 listhesis, which I think was quite important in that case. I actually would have done that also probably anteriorly, but I think there would have been equipoise in that case also. It could have been done posteriorly. So here's a case of a patient who has a subaxial cervical deformity. And so, how do you approach this? And you do this from the front, you do this from back, front and back. And I try whenever possible to avoid front-back surgery for the reasons that were just illustrated. So, but sometimes you have to do this, but you have to be prepared then to try to deal with complications and to prevent with complications. So this patient has at-disc level pathology. I like to get flexion extension films, and I use CT scans also pretty liberally here in terms of the surgical decision making. And so this patient has a reducible deformity, an at-disc level deformity, and this is managed fairly simply with a multi-level anterior cervical discectomy and infusion with a good outcome. Sometimes you need to do a corpectomy if there's a pathology behind the vertebral body, and I like to combine this with a discectomy, so a so-called kind of hybrid type of procedure. And I think the interval point of fixation, as is shown here, for example, really provides a powerful a construct, and one can avoid front-back surgery in many cases here. So here's a fairly complex subaxial cervical deformity. I combine this here with a corpectomy and with a discectomy. And I'll show you in a moment kind of some of the tricks in terms of how to do this. And then there are very good posterior approaches, laminectomy infusion, laminoplasty, and of course Professor Abumi is going to talk about posterior approaches. I suspect, though, heavily focus on pedicle screws, but we'll see this. And then for anterior posterior approaches, I reserve this largely for patients who have a fixed kyphosis when you need to do an anterior and posterior compression, decompression together, when you have a multi-level corpectomy, and then where you need to repair the posterior tension band. So I'm just going to present a case and just kind of walk you through this. So one of the things is, when you interpret epidemiological results, and Professor Farsha quoted our paper, there was actually a 17-fold higher complication rate in front-back surgery, 17 times higher, okay? Now, not all of this, though, is related to the fact that it's a surgery. Sometimes it's the type of patient that you're operating on. So this is a pretty typical patient, and a lot of these patients are what we call train wrecks in the Canadian context. And so this is a guy here, sad life. He's 58, struggled with addiction, heroin addiction, and so on and so forth, heavy smoker, he'd had multiple cervical traumas, and I'll show you what his x-rays look like. And he presents with a moderately to, or actually quite a severe cervical myelopathy, MGA 10 out of 18, a lot of neck pain, a lot of neurologic dysfunction. And he has a fixed cervical deformity. So that's his extension film on the left. And I'll show you his measurements in a moment. And so he's got about 18 degrees of kyphosis, and his T1 slope is off, and he's pretty far forward. Okay, with his and I didn't show you his 3-foot standing X-rays, but this is a cervical deformity here largely, and he's fused there in the front on the CT. That's his. You can get a sense on the CT scan what this will look like in extension, because the CT, of course, is done with the patient in extension. And this is the MRI, and you can see that he probably had an old cord injury at the level where, and this, he did not ever have surgery. So this was likely related to trauma, and he spontaneously fused these levels. And then what's occurred is he's been trying to compensate for this in the upper cervical spine. Here he's developed degeneration at this level because he's trying to maintain his horizontal gaze. And so you need to take this all into consideration when you're treating this. So how are we going to handle this? And so, you know, one of the options that I've seen presented very frequently is a back approach. That's a lot of surgery, and I rarely do that. I'll show you though what I routinely will do here. So here are just some of the MR images. Okay, so this is kind of walking you through. So I really like anterior osteotomies, and they're actually pretty straightforward to do once you know how to do this. So firstly, we rely on the positioning, and then what I've tried to show here is I've actually gone into the fused disc space. I've reopened this with a drill, and I've gone out the uncovertebral joints, and I've taken down the uncovertebral joints, and I've reopened this. Now, I could not, however, open that sufficiently to get away with the discectomy, so I was forced to do a corpectomy, and it's a bit more challenging when you do a corpectomy to try to restore lordosis, but you can. And so if you do a wide anterior release and you take down the uncovertebral joints, you can position the Caspar pins, and you want to position these in the cortical bone, and you want to use long pins so that they're bicortical, and then you can restore a fair bit of segmental lordosis. And then I've done a hybrid procedure here as well. Now, he needs to be flipped over, though, because I can't deal with everything through the front. He's got a lot of posterior disease, and so this was handled posteriorly. And in general, when I'm dealing with sort of complex deformities, I do like to supplement this with pedicle screws, and I like C2 pedicle screws, and I'll go down to T1. So how did we do here? Well, we've improved things. It's not perfect. I'll show you the pre-post films. These are the initial post-operative CT scans that were done. In early follow-up, he's actually shown quite a substantial improvement. So he's at 15 out of 18 on the MGOA. Patients who achieve a score of 16 usually feel that they're asymptomatic. It's really the doctor that picks up the residual deficit. So he's close to where he's achieved a very high degree of improvement. So we've gotten him back. A fair bit, and I think one of the things here also where judgment is required is you don't necessarily, particularly in older individuals, need to always get a perfect correction of the deformity, as long as it's functional. And it's sometimes actually a mistake to try to get people to a perfect. You set people up for distal junctional failure or proximal junctional failure, and we're learning this from the deformity field. So anyway, so we got him back a fair bit. So then I just wanted to share with you kind of the guidelines for the management, because we now for the first time actually have guidelines. And this was published last fall in the Global Spine Journal. This is all open access. And this was a multidisciplinary group consisting of surgeons from various disciplines, but also non-operative physicians from various disciplines, as well as rehabilitation people. And we had patients that were included in this. So a very broad a group. And then we did systematic reviews. We had professional statisticians doing the systematic reviews, and then we brought in the various stakeholders using the grade process. And I have to acknowledge, a lot of the very important literature actually comes out of Japan in this condition. So some very high quality prospective studies, and then we combine this with some of our AO studies that were referenced before. And then this is the forest plot here, and we see that there's a substantial degree of improvement that occurs with surgical treatment, and then this was the guidelines group. In the grade process, it was a very interesting learning opportunity for me in terms of this whole process, but I've really become a fan of this process. So you take the best available evidence, and then you have to look at the clinical acceptability. So like, does it make sense? And then but you also want to consider the patient values. It's very important, okay? Is this important to the patient? Like, is a neurological disability important? And it is. Patients really don't like having cervical myelopathy. It has a big impact on their quality of life. And you want to assess benefits versus harms. It's very important. And then you want to look at the cost. We have to be responsible, right? So we want to do things that are cost effective, okay? And fortunately, the surgery is cost effective. There are now good health economic studies that have been published on this. So for moderate and severe myelopathy, it's pretty straightforward. Patients should be operated on unless they're too sick to have surgery. Patients with mild myelopathy, this is a really interesting group because some patients remain stable for a really long time, and then there are other patients that decline. And we're not so good at figuring out which is the group. So right now, where we are, and this is an opportunity for further research. So I think imaging, electrophysiology, better outcome measures, et cetera, here are going to be very helpful. But right now, where we are, we're essentially saying that depending on the circumstances, how the patient looks, the patient wishes, the physician's viewpoints, you could either offer surgery or a trial of structured rehab. But the patient needs to be followed carefully. You can't just say, oh yeah, okay, go off. The patient needs to be followed either by yourself or by a qualified individual, and maybe that would be the general doctor, but people need to be trained in terms of the signs. And then if patients remain stable, okay, fine, but if they decline over time, then certainly they should have surgical treatment. So the take-home messages here are that some of the deformity principles are applicable in the cervical spine, and they're quite important in terms of surgical decision-making. So although, we have published that, there aren't big differences between anterior and posterior surgery, the reality, though, is that we're operating in different types of patients, anteriorly and posteriorly. But there are some patients where there is equipoise. So for example, the case that was presented before, I would say there probably is, you probably handle that case very nicely, either anterior or posterior techniques. The C2 to C7 sagittal alignment, the T1 slope, the cervical C2 to C7 SVA, for me, are the key parameters to assess. Okay, so they're very simple to do. Flexible deformities can be handled either anteriorly or posteriorly. I tend to have a bias toward anterior surgery. I like anterior surgery. And I think anterior options are excellent for at-disc pathologies. The technique of the anterior osteotomy is actually a fairly straightforward approach once you're familiar with how to handle this, and it avoids the back type of surgery. So in most circumstances, you can achieve very nice deformity correction from the front. And then hybrid options are quite good for complex anterior cervical reconstruction. Fixed deformities generally require a combined anterior posterior surgery. And then the guidelines would now indicate that surgery is certainly indicated for moderate and severe DCM, and then judgment and consideration of options for mild DCM. So with that note, I'll close. Thank you very much.